Collapse of a segment of lung occurs when the ventilation to that part of the lung is prevented. The causes of collapse can include many serious pathologies, and the collapse itself can be of significant importance. For these reasons, it is important to be able to identify it quickly. The causes of partial collapse are conveniently divided into three categories: extraluminal, luminal, and endoluminal. Each have their specific causes. The hallmarks of collapse are loss of lung volume with accompanying distortion of the normal position of some landmarks, along with classic patterns of lung markings depending on the lobe involved. Some types of collapse are more easily seen on a lateral chest X-ray. Unfortunately, this is often impractical in critical care, and heightened suspicion is required to make the diagnosis on an AP film alone. Initial scanning of the film for collapse should include an immediate assessment of the total lung volume comparing right with left, identification of the positions of the trachea, mediastinum, hilar, horizontal fissure and diaphragms, signs of rib crowding, where the ribs on the affected side get closer together due to the loss of lung volume, a careful examination of the heart borders for areas of blurriness, and examination of the film for typical collapse patterns. It is always easier to detect subtle changes by comparing with available older films. Collapsed lung varies in appearance depending on the lobe. However, in general, the appearance is homogeneous with no evidence of bronchial shadows. The right upper lobe collapses towards the trachea, resulting in the appearance of an upside-down equilateral triangle, the apex of which is at the hilum. Medially, this obscures the tracheal border, while the inferolateral edge is formed by the horizontal fissure which is displaced upwards, as is the hilum. Right middle lobe collapse can be quite difficult to spot and may appear like a minor infiltrate close to the right heart border. The key signs include loss of right lung volume, depression of the horizontal fissure, and vague blurring of the right heart border from the hilum to the diaphragm. The appearance is striking on the lateral film as shown here, a luxury often absent in the ICU. The right middle lobe collapses inwards towards the vertebrae posteriorly. This results in an opacity in the medial lower zone, but the right heart border is visible against it. Often, the medial aspect of the diaphragm is obscured. The right hilum may be dragged down by the collapsing lung. This example shows clearly the difference following suction of a sputum plug in the right lower bronchus. Lingula collapse is extremely rare and even harder to identify. The appearance of the collapsed left upper lobe is entirely different to that seen on the right. The lung collapses anteriorly like a plate against the anterior chest wall. On the AP film, this appears like haziness overlying the entire lung. This again highlights the importance of looking for evidence of loss of lung volume on the film. The collapsed left lower lobe can easily be missed as it sits behind the heart. When the X-ray is examined carefully, the lobe can be seen distinctly as an opaque triangle sitting behind the heart, with the apex at the hilum and the base at the medial diaphragm. Total lung collapse causes whiteout of the entire hemithorax. This can be differentiated from other causes of white lung, such as a dense consolidation or massive hydrothorax, because there is evidence of lung volume loss. For instance, the trachea moves towards the area of whiteness in collapse, is central in consolidation, and moves away in hydrothorax. The other cause for this appearance is post-pneumonectomy surgery. Focal areas of collapse can occur due to regional hypoinflation and obstruction. These often present as linear opacities in the lower zones of the lung, particularly on the left.